Welcome to Cognitive Changes, Understanding Members Through Distressing Behaviors and Supporting Them to Live Full Lives. This module will provide information about common distressing behaviors among members living with Alzheimer's disease and other related dementias, as well as a framework for investigating their causes and finding practical solutions. Before going further in the module, I'd like you to take a moment to locate some paper and something to write with. Throughout this module, you will be asked to write some things down. So go ahead, I'll give you some time to find some paper and something to write with. Throughout this module, you will notice questions from the UAS will be referenced. The tips, techniques, or learning on the slide will support you with the question on the UAS. The hope is, from these tips, techniques, or learning, that we can learn more from the individual living with a memory impairment. Now please think of 5 things you would still like to be able to do at the age of 80. Take a moment and write them down. Now, what 5 things do you think are important to our members to achieve? Now take a moment and think about how we can support him or her with accomplishing these goals. It can be hard to picture ourselves in our later years, but most of us can agree that we'll still have goals throughout our lives. It's important to remember that so do our members, and in all stages of their lifespans and their disease progression, they can share their preferences and opinions. They make these feelings known through their actions, choices, and body language, in addition to their words. When an individual makes your goals a priority, how do you feel? You might be thinking you feel cared for, respected, or loved. These feelings are at the foundation of good relationships, and they are crucial to meeting our members' needs. To build a relationship with a member, take the initiative to learn about him or her. You might spend some time talking or observing, or better yet, take the time to complete the Making Connections assessment in Care Compass. This will help you to do the following: determine the person's previous and current roles and interests, determine how the person wants to spend his or her time, determine barriers in the person's environment, identify supports needed for success, enlist ideas from your member and/or member's family. It's important to know about the member's interests and passions as a starting point. However, it is also important to know about the disease process as well. Let's start with aging and health. As the body ages, certain changes occur. Our organs and metabolic processes work more slowly. Our skin becomes thinner. Fat gravitates to our midsections. Some of us age more slowly than others due to our genes. But as we will see, lifestyle is the biggest factor we can control in the aging process. As the body loses some efficiency over time, so does the brain. Therefore, normal aging involves changes in memory and learning, such as increased difficulty finding words, trouble with multitasking, a mild decrease in the ability to pay attention. However, a healthy, older brain still has the plasticity to create new neural pathways. This means older adults can learn new things, create new memories, and improve their vocabulary and language skills. What maintains a healthy body maintains a healthy mind, and vice versa. Many of the threats to brain health are based on our lifestyles. For instance, some medicines and combinations of them can affect thinking, causing brain fog. Smoking can cause an increased risk of heart attack, stroke, and lung disease. Poor circulation from damaged heart, lungs, and blood vessels means the brain is working less efficiently because it is receiving fewer nutrients and oxygen. Alcohol can cause slow or impaired communication among brain cells, even with moderate use. The long-term use of alcohol causes changes to balance, memory, and emotional regulation, coordination, and even body temperature. Additionally, some medicines can be dangerous when mixed with alcohol. In addition to lifestyle factors, there are also common physical conditions that affect brain health. For example, heart disease, high blood pressure, diabetes, insufficient sleep, lack of physical activity, little social activity, and being alone most of the time can all impact our brain health by causing long-term or temporary damage. Maintaining a healthy lifestyle is the best way to support a healthy brain. Supporting a member with a nutrient-rich diet, good blood flow through routine exercise, periods of rest, and the stimulation of learning new skills and information is very important. Social interaction is also critical both for the stimulation it provides as well for the prevention of depression. We'll review these suggestions in more detail. Help the member take care of their health by getting recommended health screenings. Manage health problems like diabetes, high blood pressure, and high cholesterol. Consult with their healthcare provider to make sure the medicines are right for the member. Reduce risk for brain injuries due to falls and other types of accidents. Explore if a member has interest in quitting smoking. To support a member with a heart and brain healthy diet, consider these foods: fruits and vegetables, whole grains, lean meats, fish, poultry, low-fat or non-fat dairy products, less solid fat, sugar, and salt, proper portion sizes, adequate fluids. Similarly, create opportunities for members to exercise routinely. Research suggests physical activity may reduce risks of diabetes, heart disease, depression, and stroke, may prevent falls, may improve connections among brain cells. Recommend members get at least 150 minutes of exercise each week. Move about 30 minutes on most days, and walking is a good start. Remind your members to check with a healthcare provider for safety. If your member has difficulty with walking or has the inability to walk, it is still important to have activity. The physician may recommend partnership with a physical therapist to develop a regimen specific to your member. To maintain brain plasticity, encourage your members to keep active. Reading, learning, teaching, and socializing are all great ways to stay engaged and active. There are many opportunities for reading and learning at home. For instance, through free web-based applications, DeRote's free University Without Walls program, NYU's Unforgettables Chorus, and many more programs around New York City. Encouraging a home health aide to teach a member to cook a new recipe or learning one from him or her is a great way to stay mentally active. The local YMCA is a great resource for volunteer opportunities. Local churches, synagogues, parks, and libraries can also often provide Good suggestions. This presentation will help you better support your members. However, I want you to support yourself as well. Everyone can benefit from making a small change in his or her lifestyle to support brain health. So let's take a moment, pick one thing you can do that may help your brain. Think small, like taking a 10-minute walk a few times a week, or adding 1 serving of vegetables each day, or make an appointment for a health screening or a physical exam. I'm going to pause for a minute for you to write down what you will do and when will you do it to help you support your own brain health. Remember, start small. Choose just one and practice over time so that it becomes a good habit. And don't be afraid to enlist support from family, friends, or community groups. There is no one more important than you. So now that we've talked about brain health and healthy lifestyles and healthy diets, let's get into what is dementia. Take a moment to write down, what do you think dementia is? Okay. Who is this person? If you guessed Ronald Reagan, you are correct. The 40th President of the United States. Who is this person? She's a little tougher. If you guessed Pat Summitt, an American women's college basketball head coach with the most wins in NCAA basketball history, she was the head coach of the University of Tennessee Lady Volunteers, then you guessed right. She actually retired at age 59 because of a diagnosis of early onset Alzheimer's disease. And do you know this person? Robin Williams, an actor and stand-up comedian. An examination of his brain tissue revealed the presence of Lewy body dementia, which had been misdiagnosed as Parkinson's disease. And this person? Rosa Parks was known as the mother of the freedom movement. After her arrest for refusing to give up her bus seat during the civil rights movement, she was diagnosed with Alzheimer's disease, just the same as President Ronald Reagan. What we can see from the 4 of these individuals is that dementia does not discriminate. It affects women and men, all ethnicities, Black, white, Asian, Hispanics, Jewish, Catholic, Jehovah's Witness. It affects all countries. It affects poor and rich. It affects presidents, athletes, activists, and actors. We have a lot we still don't know or understand about the brain and dementia. Today, I will share with you what we do know and how you, as a care partner, can use this knowledge to support your members. These are the most common symptoms reported by loved ones or members in the early stages of dementia. Members may have episodes of forgetfulness, lose important items, become disoriented in familiar places, have mood changes, have difficulty concentrating, struggle to find words, show poor judgment. Often this can be about money, difficulty with eyesight, or withdrawal from friends and routine activities. Often, individuals may attempt to cover their deficits out of fear or shame. As we age, our risk for developing Alzheimer's disease becomes greater. In fact, our chances double almost every 5 years once we hit the age of 65 and reach nearly 50% once we turn 85. Though age is the greatest risk factor, in some cases, individuals from 30 to 50 years of age have been diagnosed. These individuals have a diagnosis of early onset Alzheimer's disease. This refers to a diagnosis that occurs before the age of 65. There are 3 genes correlated to early onset Alzheimer's: PS1, PS2, and APP. Individuals with a family history of early onset Alzheimer's disease have a much higher chance of developing the disease or passing the genes to a child. However, with the more common late onset Alzheimer's disease diagnosis after the age of 65, the genetic link is less defined. There is one gene known to correlate to the disease, apolipoprotein. The risk for developing the disease is slightly higher if a first-degree relative has Alzheimer's disease. Our brains are made up of billions of neurons. To stay healthy, neurons must communicate with each other, carry out metabolic activity, and repair themselves. The brain continues to build new pathways between neurons as we continue to build skills and learn new things. Trillions of pathways. Do you feel your members with a memory impairment have the ability to learn new skills? Just think about that. If you answered yes, you are correct. Our members still have the ability to learn new skills, habits, and even new routines. What happens to the brain with a form of dementia? Imagine your brain is the world's most complex subway system, and the subway trains are messages moving from one neuron to another. There are trillions of trains running through the tracks in your nervous system and your brain, all at the same time. The information being gathered by your 5 senses, the messages to your organs telling your lungs to breathe and your heart to beat, the knowledge from your brain bank, and all sorts of other data are being filtered and sorted and assessed and applied. When brain damage occurs, it blocks the path a train can take, but human beings are resourceful, and so are our brains. They adapt. So let's do an exercise. Let's look at the map. If we wanted to get from 79th Street Station to 34th Street Penn Station, we would take the simplest, quickest route. So we would take the 1, 2, or 3 train from 79th Street to 34th Street Penn Station. This is the quickest, most direct route. A perfectly healthy brain would send its signals through the quickest, most direct route as well. This is what allows all of our cognitive processes to happen quickly and efficiently. But an individual who has a damage to the brain's neural pathways has a track damage. Let's look at the map again to see how track damage can affect cognition. Now we still need to get from 79th Street to 34th Street, but there's track damage at the 50th Street station. How can you adjust your route to get to your destination? Pause a moment to look it over. You may have said, transfer to the A, C, E line at 59th Street, Columbus Circle. You are right. That would get you to Penn Station. But what if, in a few more months, there was track damage just after the 42nd Street Port Authority station? Now what direction would you take? You may have said you would transfer to the A, C, E line at 59th Street, then to the shuttle at Times Square, then back to the 1, 2, 3 line, and that's correct. You would still get from point A to point B, but you would rely on 3 extra trains and a longer route. Each time track damage occurs, you are taking additional time, energy, and processes to make the same trip. This is similar to the cognition of a member with Alzheimer's disease or another related dementia. Processes are still occurring in his or her brain, but the messages to carry them out are taking many detours before reaching their destinations. The more track damage occurs, the longer it takes. But what's equally important to understand is our members are still thinking and formulating opinions, desires, and wishes. If we give them the time to collect and express their thoughts, they can live full lives. Conversely, the more we flood the subway system with extra information, such as trains, by overstimulating the senses or speaking too much, the longer and harder it is for the member to complete and organize thoughts and actions. Giving a single train a step of instruction or question at a time and lots of opportunity for processing is important. It keeps the member independent longer and helps to maintain trust and comfort, minimizing anger and frustration. Moving too quickly, adding too much information, or taking over completely are all common triggers for agitation and anxiety for an individual living with dementia. Dementia is an umbrella term. There are over 100 types of dementia. However, the majority of cases are caused by around 10 of the most common conditions and diseases. We will speak about some of those common conditions and diseases today. Now take a moment to write down. Do you think dementia and Alzheimer's disease are the same? At this time, we are going to listen to this video to give us the answer.
What's the difference between Alzheimer's disease and dementia? Perhaps you've been confused by these terms in the past, or mistakenly thought they were the same thing? Well, you wouldn't be alone, because knowing the difference between Alzheimer's disease and dementia can be tricky. But it's actually not too hard to understand. In a nutshell, it's like the difference between shortness of breath and asthma. Shortness of breath is not a specific disease, it can have many different causes, and asthma is just one of them. Likewise, dementia is not one specific disease, it's a combination of symptoms that has many different causes, including Alzheimer's disease. Still sound a bit confusing? Okay, think of it like this. You go to your doctor with shortness of breath. To find the cause, she listens to your chest to see if it's due to asthma or pneumonia. And then she checks your heart to see if your breathlessness is caused by heart failure or a very rapid heartbeat. She even asks if you've been worried in case your breathing difficulty is anxiety related. After her examinations, she concludes that your shortness of breath is actually a nut allergy. Similarly, when dealing with dementia, your doctor needs to figure out the underlying cause. And while Alzheimer's disease is the most common cause of dementia, it's not the only one. Dementia can also be caused by vascular changes in the brain, Parkinson's disease, Lewy body disease, vitamin deficiencies, thyroid gland problems, chronic brain infections, or medications. Even a very deep depression can sometimes look like dementia. Which means if someone you love has dementia, it doesn't necessarily mean that they have Alzheimer's disease. And that's very important for your doctor to establish. Because some causes of dementia, such as infection, medication reactions, an underactive thyroid gland, or vitamin deficiencies, can be reversible with the right treatment. So figuring out the cause and a plan of action could improve your quality of life. And that's why, if you or your loved one have the symptoms of dementia, you need to see your doctor to find out the underlying cause.
As you can see from this video, Alzheimer's and dementia are not the same thing. Alzheimer's disease is one cause of dementia. When we say a person is diagnosed with dementia, we are saying that the person has a variety of symptoms. By saying that they have dementia, we are not specifying the cause of these symptoms. As mentioned, dementia is an umbrella term. It describes a set of symptoms, rather than the conditions or diseases that cause them. We are going to speak in more detail about these 4 diseases that cause dementia today. They are most prevalent and account for the majority of our members' diagnosis. Let's start with probable Alzheimer's disease. The most frequent cause of dementia is Alzheimer's disease. With Alzheimer's disease, key enzymes in the brain malfunction, causing the buildup of plaques and tangles. The plaques and tangles restrict the flow of blood and oxygen to the neurons, causing them to die. There is also an overproduction of a protein fragment, beta amyloid. It accumulates at abnormally high levels in the brain, which in turn produces the plaques. The plaques and tangles are what is causing the damage to your brain, or track damage, as in the subway analogy. At the very last stages of the disease progression, 60% of the subway system is still working. That's why a member can still learn new skills, habits, and/or routines. A healthy brain is about 3 pounds, while a brain that has been affected by Alzheimer's disease can weigh about 1.5 pounds. As you can see in this pie chart, Alzheimer's disease makes up the majority of diagnosis, with several other forms comprising the additional 38%. It is also possible to have mixed dementia, in which an individual experiences more than one dementia-causing condition. Dementia with Lewy bodies. This type of dementia attacks the nerve cells responsible for sensory input, causing active hallucinations. Dementia with Lewy bodies is very sensitive to treatment with medications, and using them can often worsen the symptoms of hallucinations and delusions. It is best to maintain a calm, safe, clear environment for the individual until the hallucination passes. Also, because there are swings in cognition, sometimes care partners can become frustrated or feel like the individual is faking. It's important to remember that these changes are a part of the disease. The frontal and temporal lobes of the brain are responsible for a person's behavior, personality, and language. These are the areas most damaged in fronto-temporal dementia. There are 2 subtypes of fronto-temporal dementia. In the behavioral variant, people affected with FTD can undergo dramatic behavioral changes that negatively affect themselves and loved ones. Memory isn't an issue at first, and FTD tends to occur at a younger age than most dementias, often between 40 and 65 years old. So dementia is often overlooked as a cause. One of the most recognizable signs of FTD is called a flat affect, meaning the person has difficulty showing emotion on his or her face. It can be challenging to tell what he or she is thinking or feeling. Members with FTD may also have obsessive-compulsive disorders, or things that they do over and over again, like underlining the words in a book or picking up small flecks of paper off the floor. Because these members tend to be young, they may have a lot of energy and strength to expend without having much safety awareness. It can be helpful to incorporate exercise into the daily routine. A second form of FTD is called primary progressive aphasia, PPA, which affects language. Individuals with PPA may be young or older. Losing words can be very, very challenging for individuals with this form of dementia. They may understand much of what is being said to them, but are unable to respond or ask for what they need. Sometimes, helping the individual to organize and label his or her cabinets with pictures can be helpful. Streamlining the environment so that things are easy to locate is important. Because the frontal and temporal lobes are close to the motor cortex, some forms of FTD are also accompanied by progressive motor decline. Some examples include cortical basal syndrome, ALS, supranuclear palsy, and some common characteristics are stiffness, difficulty using the hands, weakness, and shortness of breath. The features of Parkinson's are TRAP. Do you see the acronym? T for tremor. Your member may have a tremor in the hand, arm, or leg. R for rigidity, tightness in the muscles. A for akinesia or bradykinesia, or erratic movement or slowness of movements. And P for postural instability, concern with balance. Your member may have a risk of falling backwards. The non-motor symptoms may be more debilitating than the clinical features of Parkinson's disease. Apathy and depression are quite common in persons with Parkinson's. 30 to 50% of people experience this. Your members may experience a sleep disorder called REM behavioral disorder. When you have REM sleep, you are dreaming, eyes moving back and forth. Normally, there is a part of the brain that keeps your body from moving around and keeping your body from falling out of bed. People with Parkinson's disease have difficulty with this. They can actually throw themselves out of bed, yell, and have crazy dreams. Persons with Parkinson's can also experience a lack of sense of smell, which can precede a Parkinson's diagnosis by 10 to 15 years. It can also go along with a lack of taste. The autonomic nervous system also becomes disrupted from Parkinson's as well, especially in terms of constipation, which is usually a big problem with Parkinson's. The heart and cardiovascular system do not respond normally, and when people tend to get up out of a chair, their blood pressure may drop and become lightheaded and dizzy. Other symptoms your member may experience are drooling or excessive sweating. Some of the motor symptoms and signs of Parkinson's disease your member may experience are a soft voice. They may trail off over time as they are speaking. Your member may have a masked face, like here with Michael J. Fox. A person may look angry when in fact they are just fine and feel totally normal. Another symptom you may hear from your member is that their feet get stuck to the floor when walking across. Freezing of the gait you may hear. Many of your members with Parkinson's disease may have a stooped over gait with small movements. They may have restricted eye movements where they are unable to look up and down properly. Members with Parkinson's disease may have hands that tend to tent or cramp, especially on the side with the tremor. You can see in the picture with Michael J. Fox, his hands tenting. Micrographia is an acquired disorder that features abnormally small, cramped handwriting or the progression to progressively smaller handwriting. It is commonly associated with neurodegenerative disorders of the basal ganglia, such as in Parkinson's disease. Vascular dementia is a disease where the blood vessels in the brain are damaged, depriving blood supply to cells in the area of the brain. Common symptoms include confusion, disorientation, trouble speaking or understanding speech, and vision loss. Changes can be accompanied by physical stroke symptoms such as a sudden headache, difficulty walking, or numbness or paralysis on one side of the face or the body. Multiple small strokes or other conditions that affect blood vessels and nerves inside the brain may cause more gradual thinking changes as damage accumulates over time. Symptoms depend on where the damage is in the brain. Multiple sclerosis involves an immune-mediated process in which an abnormal response of the body's immune system is directed against the central nervous system. The central nervous system is made up of the brain, spinal cord, and optic nerves. Multiple sclerosis is an unpredictable, often disabling disease that disrupts the flow of information within the brain and between the brain and body. The progress, severity, and specific symptoms of MS in any one person cannot yet be predicted. Most people with MS are diagnosed between the ages of 20 and 50, with at least 2 to 3 times more women than men being diagnosed with the disease. In the past, it was not believed there were cognitive symptoms associated with MS. However, now we know there are. Cognitive changes affect more than 50% of people with MS. When a member has concerns with their memory and has multiple sclerosis, it will be important to identify the areas of concern. We will not go into depth, however, some of the areas may deal with information processing, dealing with information gathered by the 5 senses, memory, retaining and retrieving of new information, attention and concentration, particularly divided attention, executive functions, being able to plan and prioritize tasks, visuospatial functions, visual perception and constructional abilities, verbal fluency, word finding difficulty. Traumatic brain injury, a complex injury with a broad spectrum of symptoms and disabilities. It's a brain dysfunction caused by an outside force, usually a violent blow or jolt to the head. Symptoms from a brain injury may not appear right away. They may not be present for days or weeks after the injury. Common events causing traumatic brain injury can include the following: falls from the bed, falls downstairs, falls in the bath, and other falls are the most common cause of traumatic brain injury overall, particularly in older adults. Violence, such as gunshot wounds, domestic violence, and other assaults, and vehicle-related collisions can cause traumatic brain injury. Mild traumatic brain injury may affect your brain cells temporarily. More serious traumatic brain injury can result in bruising, torn tissues, bleeding, and other physical damage to the brain. These injuries can result in long-term complications or death. It is important to understand that while there may be physical complications, such as the ones listed, often many people who have had a significant brain injury will experience changes in their thinking or cognitive skills. It may be more difficult to focus and take longer to process their thoughts. Traumatic brain injury can result in problems with many skills, such as memory, learning, reasoning, judgment, attention, or concentration. They may also have communication problems that may include difficulty understanding speech or writing, difficulty speaking or writing, inability to organize thoughts and ideas, and trouble following and participating in conversations. There can be many cognitive challenges that a person with traumatic brain injury may experience, depending on where the damage is in the brain. We have discussed brain health and how to support ourselves. Now let's discuss some conditions that some of our members may experience. If you have a member that has increased confusion or a change in behavior, it will be important to go through this dementia acronym to rule out reversible conditions. Don't fall into the trap of saying, "Oh, it's just their dementia." The members that we support often have comorbidities, meaning the presence of 2 or more chronic diseases. The first letter, D, refers to drug interactions. Over-the-counter medications, antipsychotics, and other medications can have very strong side effects. These can actually worsen the symptoms of dementia in some cases. It is very important to observe and report changes, as well as to ensure members are sticking to their prescribed medications. E refers to emotional. The symptoms of depression can look a lot like the symptoms of dementia. Many of our members have experienced losses and may need to speak to somebody to express their feelings and have support to get back into a positive routine. If you notice a member is crying, sleeping all the time, saying he or she is not interested in anything, or making other negative statements, this is an opportunity to encourage the member to seek linkage, or if already linked, an appointment with their healthcare provider. M means metabolic. The endocrine system affects nearly every cell and organ in the body. It is made up of glands that release chemicals to control many bodily functions, including cell growth and development, mood, sexual functions, and metabolism. The process of converting fuel from foods into energy for the body to function. Although the endocrine system is comprised of many glands, all of which work together, it is the thyroid gland that directly affects metabolism. The thyroid gland is the gland responsible for secreting hormones that control the rate at which the body's cells burn fuel for energy. The more hormones the thyroid produces, the faster the chemical process of converting fuel to energy occurs. In a normal, healthy endocrine system, all the glands produce the right amount of chemicals for the body's needs, but sometimes the glands do not work normally. In the case of the thyroid, people may have either an overactive or underactive thyroid. An overactive thyroid is a condition called hyperthyroidism, and an underactive thyroid is known as hypothyroidism. Sometimes when these are out of balance, a member may have confusion and/or hallucinations. E means eyes and ears. When you have a new member that has hearing aids, it is important to ensure the member and/or family member understands the importance of changing out the batteries and cleaning the hearing aids. There are many different kinds of hearing aids. These are expensive, and it is important the care partner knows how to clean them, so you may ask them to demonstrate. N means nutritional intake. As mentioned earlier, the process of metabolism converts food into energy for the body and brain to run correctly. Without proper nutrition and hydration, the cells of the brain are weakened and do not function at full capacity. It can be challenging to support good nutrition and hydration with members. Oftentimes, small, frequent meals and drinks can help, as can environmental adaptations. We'll speak about this in more detail shortly. T means tumors or trauma to the head. Some tumors and head injuries can cause pressure on certain parts of the brain. If the pressure is relieved without permanent damage occurring, the symptoms of dementia can be reversed. I means infections. Infections like urinary tract infections and pneumonia can not only spend the body's valuable resources, if they go long enough without treatment, they can cause delirium, characterized by confused thinking and disrupted attention, and usually accompanied by disordered speech and hallucinations. A. Arteriosclerosis is the thickening, hardening, and loss of elasticity of the walls of arteries. This process gradually restricts the blood flow to one's organs and tissues and can lead to severe health risks brought on by atherosclerosis, which is a specific form of arteriosclerosis caused by the buildup of fatty plaques, cholesterol, and some other substances in and on the artery walls. In addition to arteriosclerosis, congestive heart failure, CHF, a condition in which the heart's function as a pump is inadequate to meet the body's needs, can cause increased confusion as well. It is important to know if a member has this diagnosis, as he or she may require ongoing treatment by a cardiologist. One more, sometimes reversible dementia is normal pressure hydrocephalus, NPH. Supporting a member post-shunt placement may be different from supporting other members living with dementia, as there is room for improvement. Families are often waiting to see if the individual is going to return to normal, so there can be pressure to push the individual living with dementia. It is especially important to observe and report changes on these individuals. No matter what form of dementia a member has, it is important to remember that the person comes first and the disease comes second. Treating the person is as important as treating the disease. This is an individual I had the pleasure to work with, and she was referred to me due to distressing behaviors that included combative behavior. When I completed her assessment, I was able to gather information that she was someone who was a native New Yorker, enjoyed being outdoors daily, playing tennis at Central Park, and she loved to dance. When I met her and her family, I learned quickly the family was afraid to take her outside any longer due to her having an unsteady gait, and she said some things that were not always kind. She no longer had a filter. What they had not realized is that isolating her from her lifelong habits and passions were only contributing to these distressing behaviors she was experiencing with them. My recommendations were to start adding daily walks to her routine, with the support of a physical therapist, with the end goal of making their way over to Central Park. As you can see by the pictures, they made it to Central Park. We also made it on the Spirit Cruise, where her and I were able to do some sightseeing and, of course, shake a leg. So often, when our members have a diagnosis of a memory impairment, we forget there is still a person who wants to live and experience their lifelong habits, interests, and passions. Our role as their care partners is to find ways to support them in continuing to live life with passion, safely, and with dignity. We can do this if we understand the disease process. As mentioned at the beginning of the module, the role of the care partner is to collaborate with the member to incorporate his or her goals into the daily routine. The care partner can modify the process or the environment in order to make goals achievable and provide companionship along the way. True partnership can only happen when the care partner recognizes that the person is still inside. How would you feel if you felt you were being forced to give up your house or apartment? Or better yet, have a stranger live with you or spend most of the day telling you what you can and cannot do? And I know you would not want someone standing over you while you use the toilet. We learn at a very early age this is something that is done in private. So naturally, it would feel not so comfortable to a person to have someone watching over you, especially if you have memory concerns and you do not recognize you need support in this area. When assessing a distressing behavior, observation and active listening are crucial. The information we gather can support us to understand if the member is experiencing a basic human response to stress or a symptom of dementia, or a combination of the two. Understanding the cause of the distressing behavior is the best way for us to treat it. Often, care partners are helpful, and we do not realize that by being over-helpful, they slowly take away decisions and tasks from the member. This eventually causes agitation or learned helplessness and dependence. This also does not help with the individual's cognitive functioning. Ways where we can partner for care versus give care can be done by simply changing our language. We can gain permission by saying, "May I help you?" rather than just doing the task for the individual. We can offer an invitation, "Alla, will you join me for a walk?" rather than, "Come, it is time to walk." We can ask for help. "Hope, can you help me?" Again, rather than just doing the task, involve your member. Offering a controlled choice. "Alan, would you rather help me make dinner or read this story?" Offering a controlled choice is a way to promote action. You want the member to engage in something, so you offer them a choice where both choices require the member to do something. However, they have the choice of what they will do. In order to support our members with a dementia, we need to understand some of the general symptoms of dementia. We will go through each symptom and discuss some strategies that can be implemented to support the member if they are exhibiting the symptom. As the disease progresses, your member may become disoriented to the time of day, confusing the daytime for the nighttime. We need to ask ourselves, are we contributing to their disorientation? I would like you to take a moment to close your eyes for 1 minute. I will let you know when to open them. Your minute is starting now. Now open your eyes and look around. If you could not remember what time you started this module, could you tell approximately what time it is currently by looking around? We need to ask ourselves, is the environment set up to cue your member as to the time of day? Are there other external cues that can be used to support your member? For example, clocks. Is it a clock your member can see and read? Does your member have access to the outdoors in the morning and in the afternoon? If we don't get outdoors, how are we being oriented to day and to night? Are we setting up the environment to counteract daylight savings time? When the sun sets at 4 p.m., this may cue your member that it is nighttime. So by shutting the blinds before the sun sets and turning up the lights, you are being proactive to minimize the confusion. Using orienting information throughout the day, such as good morning, good afternoon, and good evening, also inviting them to the meals, using the terms breakfast, lunch, and dinner, can support orienting the individual. Does the environment support the member as to day and date? Is there a calendar? Does the clock have the date or day on it? Does the environment support the member as to place and person? Are there family photos and items that are personalized? Are the family photos labeled with the names of the family members in a font large enough that the person can read? If we have a member with disorientation to time, place, activity, or person, these are simple, non-pharmacologic interventions that can be set up in the home. Remember, we have phones that tell us the time, day of the week, date, and when our appointments are. What do your members have? Memory loss. A person with memory impairment will begin to lose the details of his or her stories, sometimes substituting new ones. This is called confabulation. It is important that we are not consistently correcting individuals when they are confabulating. This can cause individuals to shut down or cause confrontations. We want to hear our members' voice, so if they are filling in details that may not be completely accurate, it is okay. Sometimes individuals will place important objects in a safe place and forget where they have placed them. This can result in accusations. When this occurs, one way we can support a member is by creating a template. Please see the template that was designed for a member who was accusing aides of taking her watch. This template was put next to her nightstand, and each night she saw it, she placed it in her nightstand after reading it. When she woke up in the morning, she read the template and pulled out her watch and placed it back on her wrist. Reading is a preserved skill in most of our members with a memory impairment, so templates can be a support for many situations. Templates can be helpful with individuals asking repetitive questions as well. We can create a template with the answers to the questions and point to the template each time the member asks the question. Eventually, the member will learn to look at the template for the answer. Also, keep in mind, individuals may lose their ability to remember your name, but they remember faces. So no need to say, "Do you remember who I am?" Simply encourage care partners to offer a handshake each time and say, "Hi, Mom. It's me, Netti, your daughter. I'm so glad to be here with you." There is no need to have a quizzing game. If the member remembers their daughter, they will say, "I know that." This way, the member never feels the anxiousness of forgetting. We discussed the subway system earlier. So just how much time do we give our members to find the right word? On average, it can take an individual living with dementia 30 seconds to process and respond to a question or instruction. I would like us to take a moment to understand just how long 30 seconds is. I'm going to take a stopwatch. I'm going to ask you a question, just as you would ask your member a question. Then we are going to pause while the stopwatch ticks to 30 seconds. This will help you have the feeling of what it means to wait 30 seconds. Okay, here's the question. What matters most to you? Okay, we have hit the 30-second mark. I'm sure you felt, no, that was not 30 seconds. That was too long. You might have been a bit uncomfortable with the silence and possibly drifted off into thought. Waiting for the response is a technique that takes practice, patience, and full presence. It is a technique that can make a tremendous impact on your interactions. If we don't take the time to wait for responses, our members can feel like choices are being taken away from them, may become agitated over time. They may stop trying to initiate or respond and develop learned helplessness. This can result in forgetting how to make a decision or referring to a care partner to make the decision. Now you might be saying, what happens when your member does not respond in 30 seconds? Try echoing. Echoing is simply restating the question, using the exact same words, or echoing the thought the person was sharing before he or she trailed off. So if your member was telling a story about his or her sister and a dog, you might wait 30 seconds and state, "So you were sharing that your sister and the dog were walking?" and pause again. This gives the member the opportunity to finish the story. Remember, Members with memory impairment may take a long time to find a word, or may trail off when telling a story. Utilize the 30-second technique, pause, and echo. If they make up words or use the wrong word, support them by continuing to listen actively. No need to correct, and don't interrupt. This causes them to lose their train of thought. Time can be everything you need to empower your member. Let's talk a little bit more about external cues or templates. These cues ensure members have control over their possessions and they don't lose their precious items with these simple reminders. External cues can be used for showering, dentures, hearing aids, can be used for a reminder of when a meal will be served. Here is a simple template that was utilized by a member that kept losing her glasses. As you can see, this is a simple note from her daughter reminding her to put her glasses in the nightstand. Then when she wakes up in the morning, she knows exactly where to find them. Templates can be helpful to care partners if a member is resisting a process or task. Templates can be supportive in allowing the member to complete the process more independently rather than feeling as if they are being told what to do. This is a way of empowering the member. If a member is resisting a shower, you may want to work with the member on using a calendar. The member can schedule his or her own shower, days or evenings. Here is a letter I was able to use with the member. It reads, "Hi, Mrs. So-and-so. I enjoyed our conversation. It is always so nice to talk with you. We agreed that I would be back on Wednesdays to assist you to a nice spa bath. I know you have been concerned about falling. I will be here to support you, so you will be safe. We have a nice seat for you in the bath, and we have grab bars to support your safety as well. I care about your safety too, so I will be with you. I will see you on Wednesday," and then we write in the date, "at 10 a.m. in the morning." Then we included a picture of the care partner, and both the member and the care partner signed. It was laminated and used each time it was shower day, which was Wednesdays. We wrote in the date for Wednesday each time. Here is another template. Oftentimes, as care partners, you run into touchy situations. So for example, this individual has difficulty accepting help with regard to changing her clothes, and the care partner has been running into an issue with offering choices. Mom would say, "No, these clothes are clean." So what might be helpful is using an external cue in a loving, supportive way. If you are mom in this situation, you are feeling pretty loved and beautiful right about now, reading this note. The memory deficit was not mentioned to mom. However, this daughter is able to recognize the strength that mom has. She can read and follow directions if the cue is within her vision, on the edge of the bed. The note simply reads, "Good morning, Mom. I finished the laundry. I left you your favorite outfit on the edge of the bed. You always look beautiful wearing that nice flowered shirt. Love you, your daughter, Claire." Here is another example of a template, and certainly one that many of our members could utilize. Which would you prefer? An aide telling you every day to drink water, or have some simple reminders? We are working with adults, and it can become painful to feel like you are being told what to do. This is a way we can support our members with independence. So this template reads, "Lorna, it is very important that you report when you have any abdominal pain or you feel your stomach is distended. This can be an early sign of a urinary tract infection. In order to prevent urinary tract infections, it is important that you drink lots of fluids or eat foods high in fluids. These can include water with lemon, Jell-O, popsicles, cucumbers, lettuce, celery, tomatoes. Your nurse, Beverly." This template was written with the help of Lorna. She told us what she felt when she had urinary tract infections, so we wrote that in there. She used the word abdominal pain. She also told us that she doesn't like regular water, so instead of trying to keep coming after her to drink water, we said, okay, we have a list of things. What are the things out of this list that you might enjoy having. And she picked these items, and then we put that on her reminder. And that's how this template came about. So again, partnering with your members to come up with these templates or external cues, it's important. Use their language. Use their choices. If we want our member to do something such as take their medications and/or use or wear devices, we can also use an external cue. However, it is important that the external cue is meaningful to them, such as the external cue used on this slide. In this case, the member was having a lot of pain, and she wanted the pain to go away. So we needed to mention pain in the external cue. Once she saw that this blue separator would alleviate the pain, she was more willing to wear it. This is a simple reading screen. As you notice, the font continues to get smaller and smaller. It will be important to note that some members will be able to read but unable to perform the action. You have to decide what information you are trying to gather about your member. Do you want to know if they can read for engagement, or do you want to know if they can read in order to follow directions? Or another type of reading, engagement, so that the member does not become involved in repetitive questioning. Reading can be a skill utilized for many reasons. Another symptom of dementia is trouble with sequencing. I would like you to take a moment to jot down on your notepad how you would ask a member with a memory impairment to brush their teeth. I will give you 1.5 minutes to write down the steps. Okay, now look at what you wrote. Were you giving commands or demands? Were you giving one-step invites? Were you using demonstrations? Were you gesturing? Do you think you would have rushed in and completed the task for your member? Often, our members have difficulty with the ability to take words, ideas, and actions and put them into a linear sequence. They may miss a step, or the member may repeat a step over and over again. We as care partners have to be able to communicate without commands and/or demands. Oftentimes, individuals who have difficulty sequencing, at times fewer words can be more powerful. Breaking down the steps one invite at a time and pausing 30 seconds to allow enough time for processing can be the technique you need to complete the process successfully. Also, don't forget your nonverbal communication techniques, such as demonstration. These templates or external cues support an individual who may miss a step or repeat one step repeatedly. Also, on a side note, when possible, say no to supplements and yes to food. I have worked with many members that have stopped eating because they are not offered choices and/or not part of the meal process. Try to strategize with care partners on how the member can partake in the meal process. Can they shred the lettuce for the salad? Can they slice the banana? There are safety knives, you know. Can they wash the dishes? Involve the member as much as possible. What are their strengths, and utilize them. The next symptom of dementia we are going to discuss is difficulty with concentration. I'm going to read you a brief story and then ask you a question about this story. Here we go. One day, some youths went to a jungle to practice shooting. They kept a few pots at a distance and targeted them. None of them could hit even a single pot. A saint who was watching them started laughing. One of them went to him and asked, "Why are you laughing? Do you know how to shoot?" At this, the saint took the gun and fired at the pots and smashed all of them one by one. The youths were amazed to see this and asked the saint if he was a magician. The saint replied, "I am neither a magician nor a sharpshooter. I just concentrated and the result is in front of you. One should always work with concentration." The youths thanked him for the piece of advice. The question is, where did the youths practice their shooting? If you guessed they practiced in the jungle, you are correct. However, you might have had difficulty coming up with the answer. Were you being distracted? Were you having difficulty concentrating? Are there ways that you may have been better supported in coming up with the right answer? Your members need the same supports. We need to eliminate distractions. If you are completing your home visit and they have the TV and/or radio on, ask if it is okay to turn them off while you visit. It also might have been easier if you were able to read the story yourself. So if you find a member is not responding, are you able to write the question down? I carry a handheld dry erase board with me. It is amazing the responses I get when I write a question down versus verbally asking. There are some vision issues that may naturally occur as people age. So let's discuss these, then we will discuss vision as it relates to dementia. Presbyopia usually occurs after the age of 40. It causes difficulty to focus on objects up close. This happens due to the hardening of the lens inside a person's eye. For a time, a person can compensate for this gradual decline. A person may notice that he or she holds reading material farther away from his or her eyes, but eventually may find him or herself in a CVS searching for a pair of the reading glasses. As a person continues to age through the 50s and beyond, presbyopia becomes more advanced. A person may notice the need for more frequent changes in eyeglass or contact lens prescriptions. Another age-related vision change, according to the Mayo Clinic, is about half of all 65-year-old Americans have some degree of cataract formation in their eyes. As a person enters their 70s, the percentage is even higher. Thankfully, cataract surgery is safer now and effective that 100% of vision lost to cataract formation usually is restored, according to the Mayo Clinic. If a member is noticing vision changes due to cataracts, don't hesitate to encourage them to discuss symptoms with their eye doctor. It's often better to have cataracts removed before they advance too far. Macular degeneration, also called age-related macular degeneration. As you can see from the photo on the right, a person with macular degeneration may have blurred or no vision in the center of the visual field. Currently, there is no treatment that completely restores vision lost to the eye disease. Some drugs may be able to slow or prevent additional vision loss. Many of our members may be able to keep good vision for their entire lives, and even those who lose their central vision almost always maintain their side or peripheral vision. Another common eye condition is glaucoma, which is caused by abnormally high pressure in your eye that causes damage to the optic nerve. Glaucoma is one of the leading causes of blindness for people over the age of 60. It can occur at any age, but is more common in older adults. Many forms of glaucoma having no warning signs. The effect is gradual, that you may not notice a change in vision until the condition is at an advanced stage. One of the last common eye conditions a member may experience as he or she ages is a condition that occurs in people who have diabetes. It's caused by damage to the blood vessels of the light-sensitive tissue at the back of the eye, the retina. The condition can develop in anyone who has type 1 or type 2 diabetes. The longer you have diabetes and the less controlled your blood sugar is, the more likely you are to develop this eye complication. The risk of low vision and blindness increases significantly with age, particularly in those over age 65, according to a 2004 National Eye Institute study. Vision loss can adversely impact the overall health and well-being of older adults in many ways. According to Centers for Disease Control and Prevention, there is an increased risk of falls and fractures, making it more likely the person will be admitted to a hospital or nursing home, become disabled, or die prematurely. There is also an increased risk of depression. A person may have difficulty identifying medications, which can lead to drug-related errors that affect their health. Medicines have become a leading cause of death among seniors. Many of our members take several medications a day, so it is important that they have a system that supports them in taking their medication timely and accurately. Approximately 1.8 million elderly in this country, not living in nursing homes, report some difficulty with bathing, dressing, and walking around the house, in part because of a visual impairment, according to the American Foundation of the Blind. Now let's discuss vision as it relates to dementia. Visual perception is another dementia symptom you may often see. Many times, members have trouble with their vision as part of their disease progression. They may not understand light and shadow, thinking dark shadows are holes or pools of light are wet spots on the floor. It can be helpful to make sure surfaces aren't too shiny and that rooms are well lit. Members also may not be able to see how deep a surface is or how far away an object is. Using your foot to show them how high a curb or step is can be helpful, especially when stepping into the shower. And so can guiding their hand to an object so that they can understand its distance. Using bright colors and contrast is another great way to support. For instance, if a white shower chair is sitting in a white shower stall and your member seems afraid to sit down, try putting a brightly colored towel on the seat to help the member see the edges of the chair. The same can go for a toilet seat or a chair. In an apartment, throw rugs, mirrors, and patterned furniture can also cause confusion when vision is compromised for the reasons we discussed. Observe your member to see if any of the symptoms of visual perception issues are present. If so, it might be helpful to ask the physician to make a referral for an occupational therapist. He or she can help to create a safe environment with strategies specific for your member. Field of vision narrows. By the time we are 75 years old, the normal changes related to aging reduce our normal peripheral vision a little bit, so we're not able to see and notice as much as we would when we were younger. Let's gain a better understanding from Teepa Snow, a world-renowned occupational therapist. Here in the video, she is going to explain the narrowing field of vision for a person living with dementia.
So with this disease, we know that with your 5 senses, you're going to change in your visual abilities, your auditory processing abilities, but not your ability to hear sound, your sensation and your movement, what you feel and what you do, what you smell, and then what you taste. All of those are going to change, and you lose safety awareness before you lose curiosity. With vision, your field is getting smaller and smaller and smaller. It's particularly important for us to recognize when a person's in early stages of dementia. They're a diamond. And in other words, these are Allen levels. And what we're talking about here is they have vision that's like a scuba mask. They've lost the sides and the top, but the center's pretty good. When they go from that to having binoculars, there's a real important difference, because when you have a scuba mask, what you're going to be able to do is see the plate in front of you and the person across the table. Once you develop binocular vision, you can either look across the table or look at the plate down in front of you. But you can't do both at the same time. It's one or the other. You have social vision or you have a task vision. And every time you switch, you have to readjust everything. So if I'm looking and talking at you, I don't realize something's going on right here. And if I'm looking down like this, I don't realize there's anything out there. And after that, it gets even worse, because now I look at objects and I don't know how to use them. I don't know what they're for. I see it, but I have a hard time identifying what it is and then what you do with it. So I have apraxia. And then I have to figure out, now how do I get started with this? I have to remember the sequence in the organization. So I pick this thing up, and I may know it's a fork, but then how do you use a fork? How do you hold a fork? How do you manipulate a fork? And how do you pick things up? And which things do you use a fork for, and which do you use a spoon for? It gets complicated. And then comes the time when I can't get my two images to line up, and my brain decides, well, okay, we'll just pay attention to one. So I become monocular, and I lose all depth perception. And it's amazing how quickly you can get yourself into trouble, because when you have just one eye looking about, if you were to do this, look at your index finger and then track your index finger down to touch something on the floor. What you're going to realize is you don't have a sense of how far away that is. And if you're relying on your feet and your legs and the muscles to organize things, they get tricked, because what they're relying on is the visual information to make adjustments, which means you're very at risk for falls.
As you can see, a member with aging eye conditions and now having dementia-related symptoms related to vision, it can be difficult to process what they are seeing, and often what we may think is resistance to care and/or hallucinations may be linked back to an eye condition related to their aging or related to their vision symptoms of dementia. It can be hard for your member to know if something is a pattern in the carpet or an object on the floor, a real apple or a picture of an apple, or how high a chair is. As you can see, it would be important to understand if your member is experiencing any of these visual issues, so you can support them by adapting their environment, by offering contrast and changing your approach in communication, and approaching from the front when providing the freshening up process. Let's talk about changes in the taste buds and sense of smell. Each taste bud is a bundle of sensory cells, grouped together like the tightly clumped petals of a flower bud. These taste buds cover the tongue and send taste signals to the brain through nerves. Taste buds vary in their sensitivity to different kinds of tastes. Some will be especially good at sensing sweetness, while others will be especially attuned to bitter flavors, and so on. A taste bud is good at regenerating. Its cells replace themselves every 1 to 2 weeks. This penchant for regeneration is why one recovers the ability to taste only a few days after burning the tongue on a hot beverage. Between the ages of 40 and 50, the number of taste buds decreases, and the rest begin to shrink, losing mass vital to their operation. After 60, you may begin to lose the ability to distinguish the taste of sweet, salty, sour, and bitter foods. Often, members have appetite changes as a result of dementia. Your members with dementia may not taste food and may not experience flavor like they once did, which can change appetite preferences. Because taste buds are diminished as people age, people with dementia may opt for heavy foods or foods with a lot of flavor, like sugary sweets. If food suddenly does not smell or taste as it once did, you may not eat as much as you should. You may lose interest in fruits, vegetables, and other dishes that provide the nourishment critical to maintaining good health. Because saliva production also diminishes with age, you may also experience dry mouth and have difficulty swallowing. If you are elderly, this can sometimes mean that eating becomes more of a chore than enjoyment, again, possibly leading to malnourishment. People living with dementia have shared that they have olfactory illusions and hallucinations, which causes them to smell things that are not there or can make things smell different to how they usually would. These can be anything, but are often unpleasant smells such as burning. These are phantom smells. Also, persons living with dementia can have changes to their sense of taste that makes food and drinks taste stronger, weaker, or sometimes completely different. This can mean that you no longer enjoy your favorite food and drinks. These symptoms can also change, so you may react to different triggers at different times of the day. They might intensify at the end of the day or when you become tired. This can mean that your physical and emotional responses can vary. People are often left feeling drained and disoriented because of these sensory challenges, as they impact on all aspects of life. If tea or coffee become overpowering, try fruit or herbal teas. Honey, sweet sauces, and chutneys can help to make food taste a little sweeter. They work well in savory foods such as soups and stews. Herbs, spices, sauces, and other condiments can be added to your normal meals to boost flavor. Lemon juice can be used to season your food. Ensure smoke detectors are checked regularly. Clearly label all food with an expiration date. Encourage member to keep a diary of changes he or she is experiencing, such as phantom smells and changes to his or her sense of taste. Then share this information with the physician. The speech therapist may be able to support if the member is struggling to eat and/or having issues with texture. Nutritionists can support to keep the diet healthy and balanced. Some individuals living with dementia may find it difficult to eat well with these changes. Some people lose their appetite and no longer enjoy eating or drinking. They may benefit from having a platter with a few different things to try. A few tips to keep in mind: try small amounts, different foods, finger foods, fruits such as dried and fresh. Maybe try some breads, crackers, oat cakes, some vegetable sticks, different textures such as smooth and crunchy, or different tastes such as spicy, sweet, salty, sour, and even bitter. As people progress through the disease process, they may experience agnosia, which is an inability to recognize objects, persons, sounds, shapes, or smells. This is a result of damage to the brain. Therefore, you may find that educating care partners that serving members finger foods may encourage them to eat more, so that they do not have the difficulty of figuring out the use and steps of silverware. You may have a member that needs assistance with their dining process, because there may be some functional concerns. A technique that you can utilize is called hand under hand. The hand under hand technique allows members to have independence, control over when they're ready for food to come to their mouth or when they're not ready and they can push it away. It allows them to maintain skills. It also allows them to relearn skills. It provides a sense of touch, and it also gives them a choice. You can see in this video the home health aide supporting the member using the hand under hand technique. Another symptom of dementia is your member may have changes in motor function and sensory interpretation. In regard to motor function, you may wonder why a member at one moment is able to rise from a chair with no issue, then 1 minute later need a full assist standing. Chemistry changes in the brain cause motor changes. These chemistry changes can happen second to second. It is important for us to know so that we can educate care partners that members are not being resistant on purpose. Also, depending on where the member's brain has been damaged, a member may have difficulty with sensations. They may not have the ability to feel hot or cold, so it will be important to monitor their safety around showers and foods. Another area that may be damaged is the ability to see color. This is important for us to understand because this can be a contributing factor to falls. If you are observing the member's environment and you notice the carpet is brown and the chair and couch are also brown, you may be able to work with your member to find a color they prefer and see well. Then share this information with the care partner and encourage them to order a slip cover for the chair so the chair will have contrast from the carpet and the couch. Now that we have spoken about many symptoms that our members may experience, let's take a minute to write down some non-pharmacological recommendations that you might recommend for this member's room for a more supportive environment. So let's take a moment. Go ahead and jot some things down on your notepad. Here are just a few I was thinking. Open the blinds for some sunlight to shine in. A brightly colored blanket that they preferred from our assessment we completed earlier when we were exploring their favorite color. Family photos with labels of the family members in a font size they can read. A comfortable chair for them to sit in next to their bed. A nice piece of artwork on the wall. I hope we had some similar recommendations. I'm also sure you had some I didn't think of too. Here is another room. What improvements would you suggest for this member's room? Let's take a minute. Jot some things down on your notepad. Here are some that I had. A chair that may be a bit more comfortable and with arms for support, especially when standing and sitting. The hanger with the member's jacket located in an easier access location. A blanket in the member's preferred color. Family photos so the room feels more homey. Those are just the few that I thought of. I'm sure you had a few others. Another dementia symptom is apathy, which refers to an individual's loss of motivation or interest in his or her surroundings. You may see that your member has diminished initiation, poor persistence, lack of interest or indifference, low social engagement, blunted emotional response, and a lack of insight. Estimated prevalence rates are as high as 80% in facility populations and range from 27 to 36% in individuals living at home. The incidence of apathy tends to increase with the progression of dementia. Though apathy can have its origins in physical damage to the brain, it can also develop over time as a coping mechanism. Particularly in the early stages, individuals may respond to the symptoms of memory impairment by withdrawing and isolating, out of embarrassment or fear of losing control in front of others. As a result, we hear the all too common phrase, all he or she does now is sit in front of the TV. Eventually, if the surrounding environment does not change, this becomes routine and is reinforced over time. This is called learned helplessness. So how do we support a client experiencing apathy? When trying interventions, it will be important to implement one at a time and give full opportunity for the individual to learn and respond. You always need to start off small. So one last symptom of dementia is a loss of inhibitions. So what are inhibitions? Well, a healthy brain has a function where it inhibits or stops certain behaviors or words from happening or being said out loud in public. For example, you might be angry with your boss, hopefully not, but if you're smart, you will probably stop yourself from saying all of the things you're thinking as you're talking with him or her. Or you might like the look of something you see in a shop window, but because you know there are laws and that breaking them has consequences, you will likely stop yourself from walking into the store and taking that item home with you without paying. This is because you have a healthy brain with active inhibitions. So how does dementia affect inhibitions? Dementia, including Alzheimer's disease and other types of dementia, can damage the part of the brain, the frontal lobe, responsible for inhibitions and the ability to control impulses, positive or negative responses to stimuli. This decrease in inhibitions develops in most types of dementia and is very often one of the first symptoms care partners see, even before memory loss. You might notice someone with dementia say unexpected things in response to something he or she sees or hears. The person may seem mean, rude, or even vulgar in his or her language. He or she might comment constantly on what is happening or who is in the environment. He or she might non-verbally make fun of people around by mocking them or making negative facial expressions. This is not behavior he or she would normally have engaged in, but because the area of the brain that filters these reactions has been damaged, they are happening publicly. A person whose inhibitions have been damaged may also do unexpected things in response to something he or she sees or hears. For instance, responding physically to unpleasant sensations, spitting, biting, removing clothing, either with or without the intention to display themselves, and attempting to inappropriately touch someone or something that looks interesting can all occur. Again, this is often a change in personality due to brain damage affecting inhibitions. There is no filter to help the person stop. Losing inhibitions can include being rude, saying things that are socially inappropriate. Examples may include commenting that someone is overweight, talking to strangers, undressing in public, and apparent sexual disinhibition. Examples such as touching themselves inappropriately in public. This can be embarrassing and distressing for both the member with dementia and those around them. They may not understand that what they are doing is inappropriate. It is unlikely that they are being inappropriate on purpose. When addressing the situation, it is important to uphold the person's dignity and prevent unnecessary distress. Some common causes of losing inhibition include the effects of specific types of dementia. Some people with fronto-temporal dementia experience a loss of inhibition because of damage to the frontal lobes in the brain. Needing the toilet, touching themselves, or being too hot or undressing. Try to react calmly and remember the person is not behaving in this way on purpose. In some situations, it may help to think about whether the behavior really matters. For example, in some situations, talking to strangers may not be a problem. The person may be meeting a need to be social, and the stranger may be happy to engage with them. Be aware of potential triggers. If you know what these are, you may be able to prevent the behavior from happening in the first place. For example, if someone behaves in a sexually inappropriate way when you help them to freshen up, it may be that they are misinterpreting the actions. Try to change how the care partner is approaching the situation and see if this helps. If the person is undressing, take them somewhere private and check whether they are too hot or uncomfortable or want to use the toilet. If the person behaves rudely, don't attempt to argue or correct the behavior. It may help to explain to the other people why the person is behaving in that way. It is very important to remember that the person living with dementia, whose brain has been damaged, is not saying or doing these negative things intentionally. The actions are the result of a function of the brain that no longer works. This means some very important things. It is impossible to teach the person to stop. The inhibitions are gone, so telling the person that what he or she is doing is wrong or not nice, or asking him or her to change the behavior will not fix it permanently and sometimes won't even stop it in the moment. The person may not know what he or she is saying and doing is wrong, but simply may not be able to keep him or herself from doing it. In fact, he or she may be very embarrassed afterward and apologize. This is not proof that they did the action knowingly, but rather that they realized afterward that it was wrong. Reacting negatively to a person's lack of inhibitions can actually worsen the interaction. This is because the individual may reflect your reaction to his or her words or actions back to you. Individuals living with dementia often understand emotions in others very well and respond in kind. If they sense you do not like them or what they are doing, they may respond negatively to you. This can reinforce the negative words or acts and cause them to continue or even worsen. Instead, modify the environment or apologize and step away. Look for any potential trigger for the negative communication or behavior and remove it. This may mean changing what the person is seeing, hearing, or being asked to do at certain times. Often, this is the only way to prevent the unwanted reaction of the individual living with dementia. If you are upset by the interaction, it is best to say, "I'm so sorry," and step away. While you may not have done anything wrong, there is something that triggered the individual's feeling of negativity. Apologizing can diffuse the situation quickly. Reapproach when you feel able to support the person or situation without difficult feelings. With all symptoms I have shared with you today, I also mentioned several ways we can support the member in continuing to live their lives in a healthy, engaging way. As many of you may have noticed, I did not mention medications for treatment of the disease. Often, when our members are experiencing distressing behaviors, they can be treated with non-pharmacological interventions by exploring the underlying cause. It is important that if your member has distressing behaviors, to rule out if they are experiencing an infection or experiencing pain. Often, we fall into a trap and tend to say it is their dementia, and follow that statement by asking for the member to see a psychiatrist or neurologist. Generally, a neurologist will explore medications for memory, which research has shown may slow progression if a member is in the early stages of the disease process. A psychiatrist will explore medications such as the ones listed. However, if a member is experiencing distressing behaviors due to the symptoms I mentioned previously, these psychotropic medications tend to cause many side effects that can cause more harm if there is an underlying medical reason causing the distressing behavior, such as a urinary tract infection or pain. Therefore, it is extremely important that we do not assume it is a member's dementia causing the behaviors, and we look to ensure that the individual is medically clear of other contributing factors. We look forward to diving in deeper into this in part 2 of Dementia, Understanding Members Through Distressing Behaviors and Supporting Them to Live Fuller Lives. Thank you.